occurring in developing countries, so it's not just a Western world problem. It's actually one of the most important causes of premature death worldwide, and it continues to grow. And it's predicted that by 2025, we'll have over 1.56 billion adults with hypertension. Hypertension is the leading cause of cardiovascular disease worldwide. And we know here in China, it's been growing exponentially, where in 2002, only 20% of the population had hypertension, but by 2010, they already had 34%. Additionally, we also know that people with hypertension are more likely to also develop diabetes complications. So if they have the two together, that's the group that is probably at the highest risk. The impact of hypertension can't be overstated. 1 in 3 U.S. adults over the age of 20 have hypertension. And when we look at the people who have their first myocardial infarction and have blood pressure greater than 140/90, that's 69%. For those who have their first stroke, it's 77% for uncontrolled hypertension. And for those who have heart failure, it's actually 74%. We believe that hypertension contributes to 360,000 deaths per year in the United States. Additionally, we have a lot of issues with medication adherence. It's actually quite poor in the United States. We know that at 2 years' time after being diagnosed with hypertension, only 57% remain adherent to their blood pressure medications. Hypertension as well is associated with a shorter overall life expectancy, cutting years by about 5 years of life off compared to normal tensive men and women. You can see from this slide the prevalence of hypertension in the United States. And you can see it stratified by race and by sex, men here and women here. The prevalence overall in the United States of hypertension based on the NHANES data is about 29%, but we know as we age, hypertension increases. Additionally, in terms of who has controlled hypertension, our estimates there are around 55%. And by the Million Heart Study, they estimated controlled hypertension to be more likely around 65% in the United States. In China, when you look at the prevalence of hypertension, it's approaching some of the same numbers, actually higher numbers, as I already said, in China. But in terms of awareness of having hypertension is around almost 50%. About a third get treatment. And then if you look at their control with hypertension, it's only around 10% for the Chinese population. So in both countries, we have a lot of work to do. The confusion probably about how we should deal with hypertension comes from our treatment goals. And so there's been recently a flurry of activity of everyone releasing new guidelines before official guidelines came out. There's some that we were waiting for, the one that's here released in 2014 was known as JNC8 or JNC late because it took a very long time for those guidelines to get released. But in the meantime, other societies waiting for those guidelines decided to release their own guidelines because they felt that they needed something based on new evidence to tell the practitioners. And basically, we'll go through a couple of the different guidelines if that's where we're at right now. But as I said, in about 2 weeks' time, we're going to have new guidelines in the United States. Most of the guidelines out currently all agree that the blood pressure goals had all been set at 140/90. But of course, there is new data that has come out that that's what's probably going to change in our new guidelines is whether we should have a different level of intensity to treat. Now, certainly for diabetics, different studies said different things, and so some of that made it into the guidelines, and for some it did not. For some, even related to age, they had different cutoffs. And again, I can't tell you what's in the guidelines. All we can do is predict based on the data. But here you can see just an example. This was what we call the JNC8 that came out in 2014. And these guidelines should basically stratify you as somebody who had no diabetes or chronic kidney disease versus those who had diabetes and chronic kidney disease, and ultimately made a decision about blood pressure goals based on the presence or absence of being high risk. And then also guiding on based on also race was part of these guidelines, about what type of drugs you would use for the particular person. So a little bit more aggressive, except for those people who were over the age of 60. So that was the one difference that really came out in these guidelines. They also spoke a lot about the initial management. Sorry, I really try on this computer. The management of hypertension, and of course, lifestyle changes always is part of the key of treatment. But the difference in these guidelines was for African American or our Black population, that diuretics and calcium channel antagonists were recommended specifically as first-line therapy versus any of these drugs for other races. So, additionally, they did remark about beta-blockers. The AHA, ACC, and CDC in 2013, though waiting for guidelines, they came up with a paper also making their recommendations. They also set the cutoff for 140 over 90 being the goal to be under that. And they again gave different recommendations, not race specific, but gave recommendations starting either with a thiazide or ACE inhibitor, unless there was potential for pregnancy, and then using a calcium channel blocker, and then other medications depending on other conditions present. So other guidelines have come out and really focused on hypertension, like the heart failure guidelines, even though they are not specific about hypertension. They recognize that hypertension was such a great contributor to heart failure that they said hypertension may be the single most important modifiable risk factor for heart failure in the United States. And they said that hypertensive men and women have a substantially greater risk for developing heart failure than normotensive men and women. So they focused in the 2013 guidelines on this. And they pointed out that all these risk factors have the potential to increase the risk for heart failure, but hypertension might be the strongest one that can lead to both myocardial infarction as well as left ventricular hypertrophy, ultimately causing heart failure, which was a reason that they felt it was important to mention in the 2013 guidelines about the treatment for heart failure. And then in 2017, they updated those guidelines and again made their own statement about heart failure with reduced ejection fraction, that they actually recommend that blood pressure treatment goals be under 130 for those people who have heart failure with reduced ejection fraction. Additionally, they said that if you had patients that were at increased risk for heart failure, that their optimal blood pressure should be 130 over 80. And so this was new as of this year when the review guidelines came out. So I guess the question is what should our treatment goals be, and what are the new studies that have come out that will influence these changes in our new hypertension guidelines, as I said, about to be released at the American Heart Association. I think the most important study for us to look at is the SPRINT trial. The SPRINT trial made a lot of headlines because it was a pretty dramatic finding. They looked at patients, it was just under 10,000 patients, and they had two treatment goals. They had the intensive treatment arm, which was achieving a systolic blood pressure under 120, and then they had the usual treatment arm, which was, or the standard treatment arm, which was achieving a systolic blood pressure under 140. And they looked and they saw that the intensive treatment arm had reduced cardiovascular events. They had a lower fatal and non-fatal major cardiovascular events as well as deaths from any causes. So that, I think, was one of the important studies that will influence the newer guidelines. Now, there is some limitations of SPRINT. We wrote a paper just last year after the study was released talking about the low female enrollment. We felt was not justified that everything about SPRINT should apply to every woman because there was an underrepresentation of women. And of course, when we're looking at an older population, women are the ones who tend to live longer. So that was a concern to us. And when we looked at women alone, it was their findings were not statistically significant. So we felt that for women, optimal blood pressure goals had not yet been established with the highest evidence. But there was this intrinsic interaction with the individual's baseline blood pressure, their inherent cardiovascular risk, and the degree of blood pressure reduction. And I think those are the things that we'll need to take into account when we apply Sprint's findings and whether we should have a more intensive arm. It's important to point out, though, that the Sprint blood pressure, the way they took blood pressure, isn't the way that many of us, at least in the United States, take blood pressure. What they did is they used the Omron ambulatory blood pressure cuff, and they had no health professional in the room. So the patients were seated in a chair for 5 minutes, and then 3 readings were taken 1 minute apart, and the average of this reading was the official reading. And so that this, at least we know this, the number you get is about 5 to 7 millimeters of mercury, less than what you would get if you typically take blood pressure as a physician or a nurse in an office. So again, this is the way that they did it by this image. This is the way that we often do it, which is incorrect, obviously, but a lot of people don't take the time to take blood pressure that accurately. They do it as patients running into the room in the United States, which I often believe that the blood pressure is inaccurate anyway. So what we recommend based on Sprint, when you have a blood pressure of 121, that would really equal a blood pressure around 127 or an office blood pressure around 130. So I think that knowing that is going to influence our guidelines for what the goal will be set in the new studies. Now, the Canadian hypertension blood pressure guidelines actually took into account what Sprint did, and now in Canada they have changed how they're checking blood pressure using the ambulatory blood pressure cuff, and that actually recommended doing it very similar to the setting of what was done in Sprint. So that the provider leaves the room to try to reduce the effect of white coat hypertension and eliminating conversation between anyone else in the room who might be taking the blood pressure. And then they came up with their treatment goals. Again, they decided that the systolic blood pressure of greater than 130, maybe you would have a more intensive treatment for somebody who you consider high risk. And that's what the Canadian guidelines say. Now, I don't want to get into every guidelines because there isn't enough time, but there's the American Diabetes Association guidelines, which again had the same goal as our previous guidelines, but had related to whether there's the presence of albumin in the urine or not. But you can see here for the European Society of Cardiology, the American Heart Association guidelines all released, there was just a difference in the diastolic number for the ESC. The JNC 8, if you will, and the ADA all went along with the American Heart Association guidelines, and those were the ones that were released more recently. I think those will ultimately change. I think the important thing also to remember is that in all these trials, we know it takes more than one medication to control blood pressure. If you look at any of these trials, on the mean number of medications, you can see very few had one medication. In fact, no trial has really used one medication based on the mean for the population. So cohort is another study that you might argue the intensity of treatment will change for diabetics, because in the cohort trial they actually found that there was no difference between an intensive treatment blood pressure arm versus a standard treatment arm. It was a smaller study than Sprint. It had just under 5,000 patients, and they used on average 3 medications and got the diastolic blood pressure in the more intensive arm to about 119. What they did show, though, that there is an improvement, actually a reduction in stroke in the more intensive treatment arm, despite their primary endpoint not meeting that. So the important difference is that, of course, Sprint was an older cohort compared to a cohort, and the cohort really was specific to diabetics. In the Sprint trial, 28% were 75 years or older. The Sprint trial also included chronic kidney disease, and the sample size of a cohort is about half that of Sprint, so that may have affected the findings. So I think the question people are asking is whether our new guidelines, there'll be a different cutoff for diabetics. And some people say yes. I actually don't know. I think that a cohort was certainly underpowered, and there's people that are saying that it would have been underpowered. Some of the non-significant findings would have been significant if they had more people trending in the right direction. I think when you look at statistics, the reality is if you didn't need it, you didn't pull it any way that you want to, but I think that there is some good parts, and when they follow these people out longer with the accordion trial, they did see that the more intensive treatment arm has now done better than the people that were at the standard treatment, so that may influence the findings. I think taking into account the best trial, though, where they saw really extremely low blood pressure, actually did worse. So I think there will be some caution about who we should be, how aggressive we should be. So do I know what's going to be in the new guidelines? Well, no, but it'll be released very soon. I think what you should do in your clinical practice is use how to treat a patient based on, does a patient fit the study that you're looking at. I also recommend that you use the ASCVD risk estimator, because we've updated that to include more than just risk estimation for 10-year risk and lifetime risk, but we've also been able to show the impact. And this is just an example of a patient. If I give them statin therapy, blood pressure therapy, and aspirin, I can lower the risk to 5% from what was 10%. If I just give them blood pressure medication, or if that's all they want, that I might lower the risk a little bit by make it 7.4%. It's a way to talk to your patient about what you can do. So I think the new risk estimator is really nice in that regard. But even take-home messages, of course, age is a powerful risk factor for hypertension. As we get older, there's more chances our patient population will have hypertension. Our current recommendation is currently we're achieving a systolic blood pressure of 140/90 or lower, but there may be more benefit in certain subgroups to be more aggressive, and we'll see what the new guidelines say. Again, I think SPRINT is going to heavily weigh into what the new guidelines say. In the meantime, I will tell you we're working furiously at the American College of Cardiology. I also am the editor of CardioSmart, and we make these infographics. We're already revising these infographics to express the new guidelines. So I slightly lied because I do know what the guidelines will say. Just on that note, though, CardioSmart, before I end, I just want you to know that outside of America, the number one country that uses CardioSmart is actually China. Especially our Explorer app. This country has been the number one country downloading our free app. It's made for iPhones as well as Android, so you can download it. It's quite beautiful. If you want to show, there's no language barrier here because you can use it to just graphically show lesions in the heart and different procedures, and we try to explain about the heart. Really nice ways to demonstrate things. So feel free to download it. It is free and made by the American College of Cardiology.